Welcome to the History of Retina's Leaders and Legends series. The purpose of these interviews is to capture first-hand stories from individuals with unique retinal insights of historical significance. Through these discussions, we hope to provide a fuller understanding of the evolution of both the science and practice of retina through the lens of those individuals who have actually lived it. Welcome to Leaders and Legends. Today, we're honored to introduce Dr. Cynthia Toth. Dr. Toth is currently the Joseph A.C. Wadsworth Professor of Ophthalmology and Professor of Biomedical Engineering at the Duke University. Despite initially being drawn to engineering, Cindy chose medicine, and you'll hear today how she found ways to weave threads of engineering into the tapestry of her illustrious career. She earned both her college degree and medical training through a U.S. Air Force scholarship, and after residency, she served as the general ophthalmologist for 2 years on an active duty assignment. She became one of the earliest researchers to use OCT to study retinal injuries. In fact, she was one of the first to use a handheld OCT system to examine infants, and she also pioneered the first intraoperative OCT-guided surgical system. Cindy's work didn't stop there. She helped revolutionize how doctors see and treat the retina, not only in adults, but also in the very young. At Duke, Cindy was instrumental in developing the Pediatric Eye Imaging Center, as well as the Pediatric Retina Clinic, and was the first woman to serve as Vice Chair of Clinical Research in the Department of Ophthalmology. Her blend of cutting-edge research, innovative surgical techniques, and dedication to her patients makes Dr. Cindy Toth a true leader in our field. We're delighted to welcome her to Leaders and Legends. Dr. Toth, welcome. Thank you for joining us today.
Tim, thank you so much.
But let's take it right at the beginning. So go back and tell me what your house was like before you were thinking of medical school.
Oh my gosh. So growing up in Florida, oldest girl of 5 kids, had an older brother, and I loved all things mechanical and stuff. I actually liked medical things, taking care of anybody went to the ER, I went with them. But I was very interested. My dad had a workshop, and he had lathe, drill press, jigsaw, a torch. He had everything, and my brothers got to do that, but that wasn't for the girls in the family. So I didn't have the opportunity to do that. I had told him I wanted to be an engineer, and he said, that's not really a good job for girls. He meant it well. He really cared and didn't want me to have a uncomfortable career, and he approved of medicine, so that was the alternative.
Engineering, no. Medicine, yes.
Yeah.
I kind of love that, right? But he's thinking of you as a doctor, right?
Oh, he was very supportive. My daughter's going to be a doctor and not a nurse. He thought that was great.
He gets points for that.
Yeah, he does get points for that. And it's interesting to see his, that generation and what he thought was right or wrong or protective, because he was a mechanical engineer himself, and I think he thought it was going to be uncomfortable.
Tell me how you get, from Florida into medicine.
I'm the first physician in the family. My parents were the first to go to college in their families. So I had scholarship. I was applying and looking at colleges, different places, and found out about a 6-year program at Lehigh and Medical College of Pennsylvania. That sounded fantastic. Shorter, therefore cheaper. And so applied, got in, and I had some scholarships for the first year. Halfway through, I called home, and Dad's like, "How are you going to pay for the rest?" And I was like, "Oh, okay." Well, my entire career path at that time had been as a babysitter earning money, so that didn't go very far. So I signed up for scholarship with the Air Force, and that paid for the rest of college. Doing the 6-year program meant that I went straight to med school after second year of college, and then had a health profession scholarship for that. So the Air Force really made it possible for me to go into medicine, and I really loved all my time there, even if some of it was during latter part of Desert Storm. So that was doing med school. I was then allowed a deferment, so I was able to do ophthalmology. Air Force decided at that point that I would not get a waiver any more time off to do. I wanted to do cornea or plastics at that time. So they said, we've paid for enough, so let's get you to work. So I was a general ophthalmologist in O'Fallon, Illinois, at a military airlift command base there.
I don't think people appreciate what the general ophthalmologist does in a military institution, but you're doing everything essentially, correct?
Yes. So, for instance, this was in the late 80s. Lasers weren't at every hospital and center, but it was like, yeah, I became a laser safety officer, and then we brought in a laser so I could do PRPs and focal laser and all that. So it was a lot of fun. The options you had, I was even doing buckles. I helped the plastic surgeons doing facelifts, which were a gas. I mean, it just the different things you could do. And that's when I realized that doing cataracts over and over was going to kill me.
You've had an interest, it seems, in the mechanics of things, the optics with the laser technologies and the imaging that started really early for you.
It really took off. So, as a general ophthalmologist, yes, but then I got the chance to do fellowship. So I realized I went to WashU over in St. Louis to their grand rounds, and it really was the Retina group that inspired me. Um, they just the discussions, the cases, they slammed me for a PVR case I had with a buckle and really pointed out that maybe I should have further training. And so I went down to see Mike Lambert in San Antonio, and he had a letter on his desk in bright green ink, which is Reese Lander's signature color. And he had written him a handwritten note and had said he was looking for a retina fellow. Right at the same time, I wandered in and said, by the way, I want to do retina. And so we figured it out, and I was allowed to go off for 2 years, 1 year of research, 1 year clinical, because they were 1-year fellowships at the time. And that was the like explosion of the joy of doing research.
That's kind of a game changer for many of us when that first happens. Tell me a little bit about that.
I learned to write papers. And it was basically Larry Yumland, who was the head of the lab there. He was partnering with Reese Landers. Larry was blind from diabetes. Blind with a cane from diabetes. And he was a fantastic, brilliant researcher, and taught me about thinking and pausing and scientific method and what was really required to follow a hypothesis and answer the question.
So tell me now, your fellowship's done. Take me through the start that's going to get you to Duke.
I had to finish my military obligation. So Desert Storm was going on. I almost got pulled out of fellowship early, but I got to finish, and I was worried because that was only 1 year of training. I needed every bit of that year.
Absolutely.
So I went to San Antonio to Wilford Hall, which is the largest Air Force hospital, 1,000-bed hospital. And so I was in charge of the retina service. And it was great because it's like drinking from a fire hose, but that's what you want to do fresh out of fellowship.
Right.
You're just operating like crazy. And Reese had introduced me, though, to the Army research group. They had funded our research, so we were looking at subretinal hemorrhage. And that's when I met Hilla Lewis, and we were working on clot busters and TPA, and it was just so exciting, the idea of, oh, we can take something that another field's using and apply it in ours. Extravascular application of TPA. The question was, would it even work? If it wasn't being provided with new fibrin material, and stuff from the bloodstream. So
So, where do you find the time covering the largest Air Force hospital in the United States? But you seem to be able to do it all.
well, at that time, I was newly married, but my husband was a professor at UC Davis, so we were living apart. So I didn't have much of a social life in Texas. So, and I'm a bit of a geek, so this was my getting back with the engineers. So I went across town to Brooks Air Force Base, and there was this fabulous engineer, Pat Roach, and his team, and they were looking at ultra short laser pulses and their effects on the eye. Now, there was another group, the Army, who was doing it with the cornea, and if I'd worked with them, I might have made some money. But we were looking at basically the nonlinear effects in the vitreous and retina, plasmas forming back there, what was happening with energy, and looking at safety. There was a group that was developing lasers shooting out of planes and that stuff, and they needed to know with some of the experiments, what were safe levels of laser what sort of eye protection did people need? So,
So pretty exciting, right at the cutting edge and busy clinically. So you're there, and then what?
we were working on animal models of laser injury. So part of my job was enucleating eyes after we'd created the laser lesions so that then we could process, they could do, and we could look at the histopath.
Our younger doctors have no idea because they're like, you have to do that because they want to do
OCT.
OCT.
And I was just standing in the right place at the right time. So Pat Roach had supported Air Force Office of Scientific Research, was one of the different groups that supported Jim Fujimoto and their team working on optical coherence tomography up at MIT. And he happened to show up, and I didn't know who Jim was. Actually, I knew he was Dr. Femto was because he had created the highest energy, shortest pulses for a period. So he was known for being able to chirp the pulses and create these super short bits. So when he showed up with this box and they hooked it up, we're creating a laser lesion, and they're like, all our audience knows what OCT is, but that was the first time I saw an OCT. And it wasn't a dead OCT. It wasn't just a picture that you would have handed to me and I'd be looking, oh, that's a nice picture. I'm watching the laser lesion bloom in real time in this monkey retina. So here we are looking, and there's this, like, first there's a deep bright layer, and then it increases. Then you see the cysts form on the side, and you see it move through the tissue. I mean, alive, like living tissue changing.
And then how did you translate that into Duke?
Brooks called and said they were interested. I'm sure they were looking at multiple people for faculty at the time. But Reese had been at Duke and had said, Cindy's kind of a good surgeon. You might want to consider her. And so I talked with him, and it was like too good to be true, Duke, Mockimer, machine shop in the basement, it's kind of, all that engineering stuff.
Right.
So it was a lot of fun talking. I came and interviewed, and remember we'd been doing, so with my work with subretinal hemorrhage, I thought if we did better submacular surgery, if we had better tools, and so I came to Duke, we're going to make better subretinal forceps. And that way, Matt Thomas and the rest of us, we can all be better, right? And we'll get better visual outcomes. It didn't help.
Well, the instruments got better, though. I want to thank you for that because it did make a difference when we were still operating to be able to have instrumentation that really reflected what we wanted to do. What's it like going to an institution where you have such amazing retina specialists, retinal surgeons there? What are you thinking as you're going?
It was quite a frightening scenario. I came in as, assistant professor. Jean Dewan had just left. So it was Brooks and Glenn and Bob Mockimer. Saturday morning rounds, we would go over, and at that time, patients were still inpatient after surgery. And guess what day I operated? Friday. So it was the toughest but the best postdoc as I was junior faculty, because I had Brooks saying, why didn't you do a fluid oil exchange? a perfluorocarbon oil exchange instead of a fluid gas, you wouldn't have had that slippage that we're seeing this morning, you know? And but honest feedback, like being comfortable and having people say, this is not quite so good. And I find it hard now because sometimes people aren't comfortable hearing.
I think that's true. I was going to say that, I think that you're talking about stuff that really doesn't get talked about very often, which is what does it feel like when you're the junior faculty joining a preeminent faculty? And how do you find your place in that? And how do you deal with the commentary that goes back and forth as you find your place? And not only that, you're a woman in a surgical specialty at an institution that that was pretty much unheard of, right?
So I was the first woman surgeon on faculty, and the first woman on faculty was medical retina, hired a few weeks before me.
A few weeks.
And I also learned by the different ways that Brooks, Glenn, and Robert were very different in their style of questioning and approaching what should be done in surgery and how we should improve it and, kind of dreaming about things we would do.
I think it's very interesting that you've spoken to how you get different information from different people, and you're talking about three people that are hugely important in our field, starting with Bob Mockemer. So I think you really had a good relationship with Bob that was quite unique, I think.
Well, he was amazing and welcoming to so many people. To have me walk in and he shakes my hand and goes, I've read your paper. I mean, come on. That's really a kindness. And to discuss one of my papers as, I'd practiced up on all of his and was ready, are we going to talk about the microscope, the first pick, light pipe in the eye and all. And but he was known for bringing women into the retina field. Like if you think Suzanne Binder and many others who were involved in surgery came to some of the Duke courses were co-teaching, but were engaged with him. And so I think that Robert was really a helper. He also argued for slow surgery, which was kind of an interesting approach, something that has certainly fallen by the wayside. He was like, as long as you take. Brooks was efficient, to the point, referencing the literature. Brooks he could call up article, person, and it was hard because sometimes I'd sit in my office and Brooks was on that side, and I was like, I don't have my stack of literature filed the way he does. And then Glenn would sit on the other side, and he's so connected and leading group studies, like multi-center research and getting people together on how can we move this forward. And I'm kind of like, and then you realize, I'll do my own thing. Some of it was following Mockemer. So I had the opportunity to do full macular translocation, 360.
We're all impressed that you were the one that did that.
Ah.
So tell me what that's like, because there was a lot of pushback on that at the time, and even at your own institution, there were two differential approaches to how you should operate on those patients.
I did a submacular hemorrhage in a patient, second eye. This was back in the year of disciform scars in both eyes. So the second eye, big hemorrhage and a disciform scar forming. Took out the hemorrhage, 180 cut, flip up, clean out the blood, do everything, reattach the retina. Don't get a detachment. Beautiful, and the patient had 2400 vision. And Mockemer said, if you had done a translocation, the guy would be able to read. And that was the kind of throwdown. And I was like, okay, let me take this on. So we practiced, and North Carolina is the Winston Cup racing and all that. So we practiced pit stops. So we practiced the OR steps because it took so long to do the surgery. So I practiced with the nurses our list of where were the steps that are different from normal retinal surgery and what they had to do and what what was coming next. Because I couldn't tell them how to put together the device to detach the retina. And everybody's like, you're going to detach the retina? I'm like, yes, we're going to take a perfectly attached retina, lift it off. And
Well, and I think that, one, you're developing a procedure, but two, at the same time, people didn't appreciate how long surgical procedures were. So a translocation for you starting early on, what was that time-wise?
5 hours,
5
five and a
hours.
half, 6, because they're elderly patients. I had people end up in the intensive care unit, with art line following. And that was why actually we didn't start with the pit stop things, but that's what started it. And then I went and visited Klaus Eckert. So it was all under general anesthesia. He was doing the same. He and his wife was a muscle surgeon. They came up with a way of rotating the eye back because I had some successful patients, but they walked a little off kilter. So I came back and then worked on how to isolate it. So Sharon Friedman took on the muscle surgery and I did the translocation. We did translocation first, come back 6 to 8 weeks later, take the oil out and do the muscles. And then we realized, no, don't take oil out right then. We all know it's kind of a PVR time. Like,
Right.
let's wait a little longer, do the muscle surgery. So a third one, just take the oil out. And by breaking it up, it was all local anesthesia. So I had it down to an hour and a half, hour and 45 minutes, which meant very tolerable to a patient and no longer risking the general health of a patient to do this.
So Cindy, you mentioned that, when you started, you had a lot of time because you were a newlywed. Your husband was a professor at UC Davis. How do you get him to Duke with you?
The Duke opportunity came up, and I never thought I would move him from California. He'd gone out the summer of love, and I never thought I'd get him from California to Durham, North Carolina. And he actually moved. So he came in, of course, he came in as a full professor in biomedical engineering, and I came in as the assistant professor in ophthalmology, later in BME. But he really supported my career then and has throughout. But that's been really generous of him. And in return, that's meant not necessarily jumping to different places any other time, in part because he had to restart his career. He was doing male reproductive health, and he switched then coming to Duke to female reproductive health.
You had an area that was committing you almost to one aspect of retina, which is not where you are now. So tell me how you make that transition into the person that I know.
2001, Joe Izat, who had worked with me with Jim Fujimoto, we wanted to start research together. And the first project we did, he was at Case Western, was intraoperative OCT. So he actually had a project with me, and we had a grad student at Duke, and he'd travel up there and learn from him and then come back and was supposed to build an OCT at Duke. Didn't work. And it was a postdoc. He hated gooey things. So the minute we got an eye out, he was out of the room. It just wasn't working. So basically, Joe Izat came to Duke in 2001, and Glenn and I started the Reading Center in 2001. Glenn started it. I came along as the director of OCT grading. I loved the immersion in it and the figuring out what we were seeing, and Glenn had the figuring how we were going to do this for clinical trials. He had a vision.
And the reading centers really changed clinical trials from that moment forward. I can't imagine any of our clinical trials now without an incorporated reading center. Take me back to the imaging, because let's get you toward premature infants and young eyes and your interest in looking at them.
Right. So 2001 was the start of all this getting OCT going in a bigger way. 2005, anti-VEGF came along. Gene identifying some of the causes of AMD, the genetics of AMD came along. So I worked in AMD, and at the same time, we were working on intraoperative OCT. So we tried hooking it onto the operating microscope. Didn't work very well early on. Time domain, total bust. But once we had spectral domain, we started connecting in so that by 2010, we now had a system up and going, but now we started saying we ought to have it in the OR because I believed it in having it at point of care. And our first use in the OR was actually in kids. You have a baby in there, all the adult patients, you and I, who would go to surgery on a Mac Hall, a Mac Pucker without an OCT, right? But a kid, we didn't have an OCT. So when you had that infant you're about to operate, now we had this little device. Joe Izett had started a company called Bioptogen. So he came to Duke with his handheld. And I said, well, I know that handheld thing is for animals,
But
but kids need it. And so we used it in the OR and realized kids, anytime they're under anesthesia, we can go and image. And so, I imaged a little kid that had a hemorrhage and pre-retinal membranes and imaged before surgery, operated, cleared everything off. Kid came back and we imaged OCT during an EEG while the child was sedated and found that there was a piece of membrane I'd left behind. I'd peeled a big old,
right.
Big old membrane off. You don't want to peel axons, So we took the child back and cleared that membrane, and the kid did well. But that's when I was like, I know it's going to change our world in the operating room. The same way that you and I know it's completely changed our world in clinic.
Correct.
So we continued working on that, and that developed into Bioptogen.
And with the Bioptogen, you really are responsible for sort of characterizing the development of the retinal vasculature and the retina in newborns and premature infants.
The first kid I imaged was an infant with aggressive posterior ROP. Now we call aggressive ROP. And so we look at this OCT and there are vessels all over the retinal surface. And I'm like, this is it. We're going to use OCT. We're going to show you that there are all these vessels that we don't realize are there. Of course, the next time we had APROP was not for another, 30 or 40 kids. But it got us started. It's kind of, we were standing on one foot, holding our breath. It was spectral domain. And Joe really partnered with us to get that out. And their company got it through FDA by 2012.
Tell me how we get you where you are bringing people in to transition a practice for you, which is hard to do. And then tell me how you move out of the clinic a little bit.
Yeah, so I stepped down from clinical about a year and a half ago. And I think I've been saying a year and a half ago for a while. But anyhow, but part of it was thinking about what did we need for peds. And before I retired from clinical, I got our chairman to build the Pediatric Eye Imaging Center. And so we have a center for wide field imaging, tabletop OCT, handheld OCT, visual field testing for Sharon Friedman and the kids with glaucoma, optic nerve head imaging, like all of it for kids.
I love the fact that you're an engineer in my mind, whether your dad realized it or not. I mean, you have that lab that your dad would probably kill for, and you've really been incredibly productive with it. So can't give you more kudos than that.
Well, thank you. If you look at career, whether forced or by choice, I think I've had ADD of research interest. First it was macular translocation, surgical tools and all, AMD, then really the pediatric interest, getting kind of bored with doing injections and really interested in the fact that that we could see so much and that we were learning so much every day from the adult studies and that we didn't have it in kids. So we put out a little handbook of pediatric OCT, and I just figured everybody would read the handbook, use the devices. And then we found that it was hard, that I had really amazing technicians working with me in research and in imaging. And then Joe kept building us faster, lighter, cooler systems. Christian Wieland, the grad student, made these magical little things, and we just hold them over the eye, and we'd get a picture like that. And I realized that I wanted to make it easier and better we went to a bunch of companies trying to do that, and nobody was really interested. So we formed a company back in 2020 to build a better, faster, smaller, hopefully
Less
cheap
expensive.
enough, yeah, cheaper than current camera systems, OCT that could go to the bedside. So that's my goal. We aren't through FDA, but that's hopefully in the future. And I hope to see it like at the bedside for kids for ROP. And I think it's going to make it better. The infrared light, it doesn't stress the kids.
But I think what's interesting is that, people don't really appreciate that pediatric retina really wasn't a field. And it was something that was in evolution at the time. And many people were operating on pediatric eyes and thinking they were just little adult eyes.
And a lot of pediatric ophthalmologists were thinking that this is not operable and don't get those crazy retina people in there messing with our kids. And I think that was something that was hard to get children in later with Coates disease or later with another condition that we could have done more earlier, but the world was changing. This was the era of pointing out to people, we can not just cryo, but we can laser Coates disease. That it's not the magic of anti-VEGF, it's the magic of laser. And I think that's what I've loved about it, has been the growth and evolution of so many aspects of pediatric retina. And so in my little part, I think OCT in infants and young children is going to continue to change the world of retina. That there are more people that can potentially look at a child and identify an early onset inherited retinal degeneration because you do an OCT and you're saying, where are the photoreceptors?
Well, you and
and
I,
it's easy.
yeah, and we've talked about, does this sort of generalizability move into imaging all children? I know you talk about we screen for auditory, we screen for rare genetic defects. Why aren't we looking at infant eyes? And the technology hasn't always been there, but you're moving in a way to make it available to us that becomes a reality.
I can't retire until I finish.
Correct. Correct. Well, thank you for joining us today. Really a wonderful, wonderful job and an incredible career that still has lots to give back.
Thank you, Tim.